Good afternoon. I'm Lorna Lucas, Director of Provider Education for the Association of Community Cancer Centers. I'm eager to introduce Dr. Sarah Hudson-DiSalle as our expert presenter for the 8th e-course of our series hosted by the Institute for Clinical Immuno-Oncology, or ICLIO. As you may know, ICLIO is an institute of ACCC, and we're the only initiative to prepare multidisciplinary cancer care providers for the complex implementation of immuno-oncology in the community. The ICLIO program provides a host of educational resources and tools such as webinars like today's, newsletters, e-learning modules, tumor subcommittee updates, and an immersive IO preceptorship, as well as other live meetings. Now for today's e-course, I'm pleased to introduce Dr. Hudson-DiSalle, who's a pharmacy manager at the James Cancer Hospital and Wexner Medical Center at The Ohio State University. Dr. Hudson-DiSalle is responsible for overseeing, coordinating, and advocating for the award-winning Medication Assistance Program for inpatients and outpatients. She's been successful in the development of services aimed at improving access to medications across the Ohio State University system, as well as maximizing any off-label medication reimbursement. Dr. Hudson-DiSalle is also active in pharmacy organizations at a local, state, and national level. She serves on the Board of Charitable Pharmacy of Central Ohio, and she serves as a legislative committee at the Ohio Society of Health System Pharmacists and on the Health Policy Committee at the Hematology Oncology Pharmacists Association, or HOPA. Now for a few housekeeping notes, please feel free to submit any questions you have to our presenter by typing your questions in the box located on your dashboard. I will pose all questions to Dr. Hudson-DiSalle at the conclusion of her presentation. The webinar will be archived and available on the ICLIO website, which is accc-iclio.org, by probably early next week. So now I'll send it over to Dr. Hudson-DiSalle to kick off the webinar.
Good afternoon, everyone, or good morning for some of the folks that are on our West Coast. Sarah Hudson-DiSalle. I am very happy to be able to talk to you today with kind of around coverage and reimbursement and actually apply some case studies today. So this is just a small sampling of some things, but maybe also of kind of to add on to the presentation that we did previously to maybe give you some real world experience and moving and dealing with some of these IO problems and give you some solutions of moving forward. Next, please. Now, I do plan to talk about a few off-label indications, but other than that, I don't have anything to disclose. Next, please. So for the objectives of what we're going to talk about today, we're going to look at identifying appropriate steps in developing an insurance payer reconsiderations for immuno-oncology agents, methods to prepare, submit, and manage a predetermination for IO products, also in the process of an appealing a denial for IO products, which if you're talking to your folks that are handling your billing, there's probably a bunch of them in there. And then also a process to ensure medication access for those patients that have been rendered uninsured by an insurance denial. Next, please. Now there are 40,282 words that begin with the letter D in the English dictionary. And for the folks that handle billing, denial is the worst word in that 40,000 grouping. But one of the things you need to be able to be adept and have your folks that are handling denials, how to be able to control them. So this is a list of possible denials that happen. Probably most readily, we see lack of pre-certification, medical necessity, experimental, investigational. But then also, how do you handle some of the other agents that come up? And for today's presentation, we're going to kind of talk about medical necessity, experimental, investigational, because those are probably the most prevalent of a lot of the things that we see. Next slides, please. So one of the things of when you get a denial, it kind of plops in your lap and you have to figure out why. what's the root cause that's causing that medication to be denied? You know, is it something with a payer-specific policy that they're asking for some additional information that you need to show that IO agent's being used appropriately? Is it an ECOG score? Is it because you're using it in combination with another medication? Is it because the local coverage determination is lacking that diagnosis code that's there, or the national coverage determination, if there's one present, is it lacking some information? Is there pre-certification, pre-authorization, was it completed, or did it get missed? Did it expire? Is there enough units with that? What type of documentation that's being sent? And when I talk about documentation that the payer sees that, you know, we talk about like digits and codes and various things that go across electronically to our payers. So they see the NDC code, the J code, the diagnosis code, and do those match up for what's been pre-authorized? So, you know, if you have like a series claim bill for a patient, so for nivolumab, for example, but then also the patient had a chest x-ray, and let's say around, you know, they had some other type of cardiac issues, and your bill comes out for coding all on cardiac issues, you're not going to get paid for that chemotherapy for the nivolumab for a metastatic melanoma because the coding's not there. So one of the things is the information that's in your medical record accurate for those coders to take that information out. And then the other thing is probably a good takeaway is some denials with your trends for the payers. Are there specific drugs there they are focusing on? Specific diagnosis? Is there actually even charge threshold? Is it anything over $50,000 is going to get denied? Those are things that you need to make sure that you take into account when you are approaching any type of denials. Next slide, please. With that, we're going to actually start into some cases here. So I've put together initially some cases with denials, the big D. So our first case is a patient. We had a request for the combination of ipilimumab at 3 milligrams per kilogram and nivolumab 1 milligrams per kilogram every 3 weeks in a combination, then followed by nivolumab 3 milligrams per kilogram every 2 weeks for metastatic melanoma. And this is a patient that he's doing great. His payer was Anthem, so the prospective cost of therapy, and the cost I actually used ASP charges. So across for the presentation, all of cost is based on those average dose with ASP costs. So the level of evidence for this therapy, NCCN gives it a level of a 2A. Actually, in Anthem's clinical policy, it recognizes this as a possible therapy for this patient's state, for this patient's presentation. Next slide, please. So initially what we think with it, okay, we've hit, and the case meets NCCN and Anthem's clinical policy guidelines, check. Prior authorization, has occurred. We did, everything that we should have done. And that concern for reimbursement, we're pretty confident that it's going to go through. But what was the next step that happened? It actually got denied for experimental investigational usage. You're going to see a little pattern with this with Anthem. Pretty much anything that's come across the board for them, they will deny things at experimental investigational for nivolumab, pembrolizumab, and also the combination of ipilimumab and nivolumab at this point. So next slide. So what we did is we compiled and created a compelling story for this patient's case. We said we put together an appeal that included both our infusion orders, our pharmacy records, including the nursing administration records, which is very important. The performance status assessment for that patient when they came in. Either we have our ambulatory nursing folks actually do that performance status for our patients and record the information, as well as our clinical providers. Some will include that in their notes, others do not. But also those prescribers' clinical records, any type of labs that actually come out, lab scans that show that the patient, as far as that prove their diagnosis. Authorization from AIM, there is their third-party administrator that does prior authorization services for these patients, as well as, and the one thing that is not included here is peer-reviewed literature. That was also part of the packet that was submitted for this patient that shows the study as well as the NCCN support from the compendia. I know not all of you may not have copies of that compendia, so if that is something that's accessible to you, it's always a nice support of being able to access that from some of the information. But you can also get some of the information from the pharmaceutical companies. Sometimes that they will give you peer-reviewed literature if it's out there, or if there's any compendia information, sometimes they'll do that. So we appealed this case, and it's provided all the information and showed within Anthem's clinical policy how this patient met all of the criteria, and they turned around and paid us. So we're going to move on to the next case. Case 2 brings us a request for Pembrolizumab, 2 milligrams per kilogram every 3 weeks for metastatic melanoma to the lymph node. This patient had a managed Medicaid plan, and Caresource is one of the companies in the state of Ohio. This is the prospective cost of therapy. It's FDA approved. NCCN supports this for a level of evidence of 1, and there is a clinical policy for the payer. Next step. So, really, initially, we thought this would get approved without any issues. We got it pre-certified, everything along that line, and it came back as denied. And there again, we were like, well, why? What was wrong with this? As far as, did we admit any information? Was it a wrong code that got put in? And then it came down to, we were looking at everything and actually didn't look at the clinical policy superly close to this for this patient. So the clinical policy, is it outdated? Next. We actually found out the clinical policy was outdated with the BRAF testing that was required prior ipilimumab therapy. So this was after this had been changed through the FDA. So we actually submitted the appeal initially to the clinical reviewer with the information as well as the FDA information. They denied it. We set up a peer-to-peer to be performed. Then there was a little bit of miscommunication, which I'm sure never happens to anyone else, between when our clinician called and when the person at the other end, they couldn't find the case. Never happens. Absolutely, that one of the things of keeping doggedly and starting to talk to another clinical reviewer. So basically, one of my nurses got on the phone, started calling anyone that would actually talk to her, and we finally got connected with the pharmacy director at Caresource, who said, this doesn't sound right. Let me look into this a little bit more closely. And then within, we had a call back within 48 hours and said, absolutely, you are absolutely correct. I've looked at all the information. We're going to put this through, and there was, the appeal was successful. But part of it, that is probably that take-home message for that, is that you need to be familiar with your clinical policies that are being performed or that are out there from your payers, and can you help to submit that information to your payers, that they can make informed decisions based on the most up-to-date clinical information that's available from the FDA as well as NCCN. Next slide, please. This brings us to our third case, which is for a request for nivolumab, the 3 milligrams per kilogram every 2 weeks for metastatic melanoma to the lymph node. And this patient, specifically, they had original Medicare. Cost of therapy is $150,000. They're FDA approved, NCCN supported by level 1. The local coverage decision supports the diagnosis for both of these indications, so it's listed. Really don't think that there's going to be much issue. Let's go on to the Next case, and from original Medicare, we wouldn't have to have an ABN signed. So really, this should be approved without any issue. So, lo and behold, this appears in our denial queue. And it was denied for medical necessity and units of service that exceeds the maximum acceptable limit. And so what that is with Medicare, they will look at and they'll say, here's our max dose. Here's our max dose that we think an average patient should get. And, so why did it get denied? Was it because of the coding? Did the coding get put in wrong? Or, did the charge get dropped incorrectly? Did we really give this, the amount that they said? Absolutely, yep, okay, we looked at our records. The issue is this patient weighs 160 kilograms. And at the weight-based dosing for this medication, that dose comes out at 480 milligrams. So I was going to say, if you're from Central Ohio, sometimes we have a little bit larger population. How do you deal with that? So next slide, please. We basically submitted the appeal, and now with Medicare, you have to be very, very meticulous in the appeal that you send. You need to make sure that you have a Medicare redetermination form that always is your cover page for that when you send that to Medicare. You can either upload it typically electronically or mail it, but it needs to have specific information filled out. But you also need to make sure your infusion orders, your pharmacy records are there, your nursing administration records are there. If any of those information are absent, you will have a denial from Medicare. Regardless of if you're on the diagnosis is on the LCD, you have justification for those units. We send in also the prescriber's clinical records, any type of labs or scans that are applicable to this. And I apologize, actually, we did not have authorization. You cannot ask for authorization from Medicare. So that is, I apologize for that error in there. But so with Medicare, we're asking that ahead of time. But then we also had the clinical, the weights for that patient that showed that that patient did absolutely need that 480 milligrams. Patient's actually still getting dosed currently to that, so the dose currently has been decreased for that patient. And ironically enough, from when that dose has been changed from Medicare, when the FDA changed the labeling for nivolumab, it has stopped. We've stopped getting denials for that. So it actually is kind of interesting to see. So I've had to do each month that this patient has been getting this medication at 480 milligrams, we've gotten a denial from Medicare. Next slide, please. So we've kind of talked about, as we're moving out of our denial screens as far as moving forward and having our getting through those D words, but we're going to switch gears a little bit. We're going to start to address working with our new immuno-oncology agents, so anything that's new to the market, as well as agents that that possibly you're going to be using off-label. There's a lot of literature that I'm sure that everyone is aware of that are out there for combination drugs or in various disease states. So how do you work through basically doing a predetermination? So next slide, please. So a predetermination is a little bit different than a prior authorization. You're going to the insurance company basically for those payers that you're able to and asking permission ahead of time for the ability to use that therapy for that patient. Or if there's in lack of a clinical policy for the new agents, basically saying, here's what this new agent that's on the market, we would like to use it, and this is why clinically it is efficacious for this patient and it's safe to use. So, the first step in is that of talking with your payers. You have to be super, super duper clear when you start to talk to someone. It's off-label for a cancer therapy. It's not, anytime you say pharmacy or outpatient, any type of drugs, they try to transfer you to the pharmacy benefit with that. In 99% times of the case, unless they're doing authorizations across the board, you need to say, no, I need to get to a clinical nurse review, or you need to figure out for the the company that you're dealing with is what's the terminology that they use. Do they use as a medical review, case management, predetermination? If they don't have a predetermination, you can ask for a complementary predetermination, because many times they'll say, you know, this drug does not require prior authorization, so we can't do anything. So you can ask for a complementary predetermination for that. So basically you have someone that is reviewing that clinical information, and you can come back and say, you know, we had a clinical reviewer look at this information. And then ask if the, you know, some companies will authorize it, others won't. It just kind of depends on how they're structured, but going through that process and keeping all that documentation is super important. So any type of authorization that is granted from a predetermination, please make sure that you keep that and file it someplace, or that someplace that if it's in a denial on the back end, that they can use that packet to do an appeal. Next slide, please. So these are your basics. You think about telling a compelling story for your patient. You know, you have to relay all of the facts in a compelling fashion. You know, and sometimes you can put in some nice pieces of information, especially if a patient's gone through multiple lines of therapy. Or why does this clinically fit? You know, for therapy rationale, why does this fit for the patient to receive this medication? So you know, this is a list, and you can use this moving forward, but making sure that all of these check boxes occur every time that you do a predetermination. And with that, we're going to go next. We're to our fourth case. This is a case of nivolumab that is 3 milligrams per kilogram every 2 weeks for metastatic epithelial sarcoma with metastatic disease to the lung, scalp, kidney, and soft tissue. And this patient, basically, they have an insurance. They've gone through multiple lines of therapy for this medication. Actually, there's some good case studies that are out there. Next slide, please. And, you know, really, this patient failed multiple lines of therapy, super aggressive disease. There's limited data. You know, kind of for us, you know, there's some concern with that, of going out and putting together, you know, okay, we're not certain, is this going to deny on the back end, or is it going to be approved? So one of the things that we do at the James is we use the enrollment form, and we do this for a lot of our high dollar medications. So it's not just nivolumab or pembrolizumab or or you know, any of the other PD-1 agents. Atezolizumab, sorry, I was trying to spit that out and I couldn't get it done. But we complete a benefits investigation form that is done through the pharmaceutical company, and actually we'll start that process and we get a full benefits investigation for the patient. But that also enrolls them in the program. If we end up with a denial, we can then start down the avenue of if the company is open to doing any type of patient assistance program for that patient, that it starts the process already. So we have a signed form at that when the patient comes in. It takes a village to make sure that this happens. It's a lot of coordination. For probably a smaller practice, it's a little bit easier. So I have a lot of helpers and a lot of people that we have at the James that help us to get these signatures from our patients. But back to our case, this patient actually, we submitted a predetermination, so our compelling story, that we put together the case example, the lines of therapy, the data that was there, and you know, put it to the clinical reviewer. Next slide, please. And so we were, you know, initially denied for this. We weren't surprised. We actually did a peer-to-peer. We set up a peer-to-peer with the clinical reviewer, and that denial actually was overturned. So the claims were submitted, and we weren't really surprised, and that once it was submitted, actually the claim was denied again for experimental investigational. But doing that appeal, we had everything that we needed. We had, here are our case studies. Here is our initial letter for the predetermination. Here's when the predetermination that was done. Here is, you know, the information for the peer-to-peer. So it is, you know, we were successful in getting that. Now, each month that the patient gets the medication, we have to do another appeal on the back end. So it is a lot of work that comes into play with that, but of having that information. And so my folks that do the predeterminations also work on appeals, and so they sit in actually the same room, so they can turn around and actually go and get the file. We have a lot of these electronically filed as well, so that helps us is you know, trying to make sure that everything's in, our I's are dotted and T's are crossed. So that is kind of our outcome for case example 4. Can we go to the next slide, please? Our 5th case is actually another case of nivolumab, and now this is an off-label indication. It was nivolumab every 3 weeks, every 2 weeks for stage 4 breast cancer. Now this is another patient that had gone through some multiple lines of therapy. There are some evidence that's out there, but the patient has original Medicare. So we really can't go to anyone and ask for permission. The diagnosis is not supported by the LCD. There's not really enough sufficient evidence for us to take that information to our local contractor and ask the LCD to get expanded. But for this patient, really, that really wouldn't help us. Next slide, please. So what do you do with this patient? So they're not supported by the LCD unless your patient's independently wealthy and they're willing to pay for that. Now we have had patients that have said, I don't care the cost, I want to be able to be treated. You know, that's an easy day for us of being able to do that. But that's going to be your exception versus the rule, unless you're in you have a pretty wealthy population of folks. But there's not any compendium support for this diagnosis. You know, we know for certain Medicare is going to deny this claim. So what are the next steps that we have? The patient wants to go forward with therapy. Our physicians and treatment team felt that this was the best therapy for that patient. So first and foremost, we did let the patient know of they were served an advanced beneficiary notice, knowing that that patient would be responsible if there is any type of denial, and so the patient had informed consent going forward. But then also at the same time, excuse me, I'm sorry. At the same time, we submitted information to the pharmaceutical manufacturer through Bristol Myers Squibb at the time, along with the information that the patient had to meet income criteria, as well as that it wouldn't be covered under Medicare. So we provided the local coverage decision to Bristol Myers Squibb. Next slide, please. So the patient was accepted in the Bristol Myers Oncology, a patient assistance program, to receive free medication. We deliver those ABNs to the patient has to sign actually 24 hours prior. At the James, my staff actually will deliver ABNs. We have a notification process that occurs for that. So it actually works in hand when an off-label indication starts, and our nurses do let our coordinators know if something needs to be delivered. And then, so this patient was able to get therapy even though she'd been rendered uninsured by that insurance situation. Next slide, please. So the last portion of this is the redetermination process. Next slide. Now, the redetermination process is when you start to look at medical policies across the board, so whether they're, and probably for the majority of this is where we have been most successful is with our governmental payers. So for your local contractors, for those local coverage determinations, basically you are doing a reconsideration packet. So basically you're asking that local contractor to reconsider the local coverage decision as it is to include other information. So you haven't asked them, so it's a little bit, they term it reconsideration. You really haven't addressed them initially about this, so they're not reconsidering an initial decision, they're reconsidering adding the other ICD-9 codes or ICD-10 codes, pardon me, around to a local coverage determination or an indication with specific instructions along that, depending on how your MAC gives out information. Cigna Governmental Services, our local determination actually has just ICD-9 codes, and then there's some other articles that help to guide us along that way, versus like NGS, where they actually will give you paragraphs and more of a written clinical policy to work with. So the request needs to come from a physician. So typically we have our medical director that will sign off on that, but I have a clinical pharmacist that works with many of our physicians and our specialty practice pharmacists that will provide kind of that compelling information. Basically any type of phase data that is available. So you need to, for any type of reconsideration processes, you need at least one phase 3 trial, 2 phase 2, sometimes a phase 1, clinical information from peer-reviewed journal and published evidence, if it's available, to provide. So the more evidence, evidence is king. So the more information you have, the better you're going to do. So you also want to be able to identify then other MACs that maybe have, these indications already included into their local coverage determination. There's a push for a lot of the MACs to be uniform across the country, so that does help your case, because they don't want to have any type of disproportionate share or care that occurs for patients, possibly if they're seen in different parts of the country. Next slide, please. So the case that we're going to talk about is the recent coverage expansion for Cigna Governmental Services to our local coverage determination for the drug of Pembrolizumab. We requested, there was an article that had some research that had come out around Merkel cell carcinoma and the use of Pembrolizumab. And so basically we needed to show that the information that was published on how that relates and how it would be beneficial to your Medicare beneficiaries that would need Pembrolizumab. Next slide, please. Initial thoughts was, did we have a request for therapies for those prescribers? And kind of talking to our physicians, that could be, they could see that they would have some patients that possibly down the line that could benefit from Pembrolizumab. We had actually already had at least one request for the medication, and so we looked at what the available evidence was there. Did the evidence display safe or tolerable therapy? And the level of evidence in question for this case was the New England Journal of Medicine article. And so basically, we put this information, the background of the disease, the summary of the supporting clinical evidence for Pembrolizumab in the treatment of the Merkel cell carcinoma. Next slide, please. And we put that summary together, and so CGS reviewed that. It went to their chief medical director, signed by, there was a packet of information that went. You can submit this electronically. It's a little bit hard, especially if you have more information, because there's only so much data that you can submit. So you can submit that via FedEx, but we were able to add an additional 30 ICD-10 codes to our local coverage determination for that. We've done this numerous times with our local coverage determination, as far as not just for the drug Pembrolizumab, but other drugs across kind of across the spectrum in cancer. And there are also some additional codes that we are currently working with for atezolizumab to expand that local coverage determination currently. Next slide. So that kind of brings me to the end of our talk. I know it didn't quite go the full hour, but this kind of gives us a little bit of a case of taste of some of the cases that are out there. There are you know, probably the PD-1s currently have a big target on them from some of the payers. There's a lot of scrutiny on the use of these agents. We probably have, we're actually looking currently for a trend with a couple of our payers that we're pretty sure that they're denying any PD-1s that are coming in. So, you know, looking for those trends with your current payers, especially your commercial payers and Medicare Advantage plans, I would encourage you to start asking some questions. So if you're not, you know, super in the middle of it, I would start to ask those questions. What type of support do you need? What other things that you know, can we make sure that you have all of the resources that you need? Or if you're doing those appeals, what other resources would you need to make sure that you can make a compelling appeals to the payers to make sure that you're paid for the therapies that you're giving to your patients?
Great. Well, I wanted to say thank you so much, Sarah, and we do have time to take some more questions. So quite a few have come in, so I'm going to pose a few here. And again, you still have time if you'd like to get a question in here. I might be able to get to them as well. So the first question is, can you kind of just review or go over your institution's process for ensuring that patients have access to these patient assistance programs? And how involved would you say your pharmacy department is in managing that process?
Absolutely. So the first part of the question, our institution's access to the pharmaceutical programs. I kind of have a unique role in that I have two teams of people. I have a team that they are coordinators that are medication assistance program coordinators that their sole purpose is to help patients access medications, regardless if they're uninsured or underinsured. So when these patients come into our institution, we find them in a couple different ways. We find them through, we have a cycle 1 day 1 report that appears, but really initially, especially with some of these high dollar agents, when they're seen in clinic, we work with our clinic nurses that we have some of the information pre-printed, and then we have the patient complete one of these pharmaceutical forms. The clinic nurse will then work with our specialty practice pharmacist, because sometimes there's dosing information that's on these, unless you're Bristol Myers Squibb, which you took off your dosing information on your new forms, which is going to be interesting moving forward with their new forms. But that information then gets sent to, I have a key person that will enroll the patient into, that does the benefits investigation. And at the same time, I have our predetermination team that is my other arm that work to authorize the medications through the insurance. They are working on that, trying to make sure that the patient's on track to get therapy on time. So while that benefits investigation is occurring, we are ensuring that the patient then has the ability to afford the medication, and then if there's any type of denial, the patient's already in the program, so then we can either get them, it helps that process to move along so we don't have a delay in therapy or a smaller delay in therapy, because then it starts in that patient assistance process that the patient has to be reviewed for financial criteria. So whether that, each company has a little bit different process on how that works, but we've been able to get that signature for that patient. And so the pharmacy department here, and the second part of that question was, how much role does the pharmacy department have? We actually sit in the pharmacy department. It's one of the things that our previous director had a very strong passion that, anytime you're dealing with medications, really, especially the receipt of medications, the oversight of that, it needs to occur in the pharmacy department. Not all of my, so my staff, my coordinators actually are, most of them are social workers by trade, so they don't have a clinical background, and my reimbursement reimbursement staff, the majority of them are nurses, and so some of them have worked in oncology, and so they have, but they're not pharmacists. So I do have a couple pharmacists that work for us, but the thing is, probably the best look of that is the oversight is in pharmacy. So we try to make sure that we have good practices in place for the receipt of drugs and making sure that the patient gets the medication or it gets delivered to the infusion suite where that specific patient is going to have the medication done in a safe and effective manner. And then my coordinators will then work with our billing team on the back end to ensure the patient doesn't get charged. So I hope that helps to answer that question. I'm sorry for the length in it.
Oh, great. Again, thank you. You know, you're the expert, so thank you. And then has there ever been a case where coverage was denied for use of an immunotherapy because of a negative recommendation from a non-NCCN compendium, even though NCCN provides a category 2A or above rating?
You know, we have not had that incidence recur other than that kind of that case that I brought forward where the clinical policy was not up to date. And that's probably going to be, the clinical policies many times will be of the kind of the standard for some of the insurers, and the compendia, we've been able to, you know, I think we've pushed in many of the payers, at least in Ohio, view NCCN compendia as kind of that gold standard. So we have not run into that incident. Okay, good to know. And then how long do you say, you know, typically the appeal process takes after receiving a denial from a payer to cover an immunotherapy? So depending on the payer, it will take anywhere for once they receive the information from it, they may take up to 30 to 60 days is probably a good rule of thumb. Others will turn it around much quicker, and depending on your managed care team's persistence and as well as your rev cycle. So some of our payers, they actually have, either monthly or bi-monthly meetings with some of our payers that go over some of the high dollar accounts, and we've tried to communicate with our rev cycle, so any type of high dollar J code threshold, they actually appear on their report, and they know once we've completed our appeal, they start to ask on a pretty regular manner, is this resolved? Is this resolved? And so that information, it kind of helps to push a little bit. It's not always effective. They sometimes they'll say, well, it's going to be 30 to 60 days. We know it's been received, and it's being reviewed. So sometimes that's your standard answer. Okay, great. I think I have time for just a few more questions, so I'll get to a few more here. Are you finding that payers are having difficulty keeping up with their coverage policies regarding IO, or are they getting any better at this? I think from the initial, for keeping up with the cases, much better than it used to be. When Pembrolizumab and nivolumab were first introduced, it took a good 6 months for a couple of the payers to even have a policy in place, and then it's pretty. They will, many times the payers will look at these drug classes sometimes only once a year. Well, with the immuno-oncology agents, they've actually been looking at it more on a quarterly basis, on a much more regular basis. And so we will see with the changes in the FDA approvals, those are the things that we do lack. So usually with even a request for prior authorizations for something that's now FDA approved, we'll submit a copy of the FDA label that reflects the new indication, just because usually that policy is not going to be updated for another 3 months. But it's getting better. Good to hear. All right, I think I can get to one more. So with regards to denials of coverage, when coverage cannot be obtained, are there any other options for patients besides perhaps, the patient assistance programs or clinical trials that you're aware of? Not so much. Other than paying out of pocket, we have been, we have worked with some self-funded plans. And so it kind of becomes, you have to kind of take a step back and look at the patient's coverage. With a self-funded plan, many times the patient can, really work as an advocate for themselves and go to the plan and, kind of make their case to the plan and say, I'm paying for this insurance. Here's why that my team feels, my doctors feel that this is the most important therapy for me. You're denying it. And, in some cases, we've been able to get them to open up that clinical case. I have not had that with an IO agent yet, but with that philosophy has worked in other instances, and they reopen the case, and usually they appeal it. Probably it's 75-25% of the time, but it takes some advocacy work for the patient on, sometimes it's themselves, sometimes it's a spouse, sometimes it's a caregiver of someone that will advocate for that. Usually when talking with the plans, they won't talk to the provider. So that's where engaging your patients many times is another avenue, and then kind of another tool to put in your tool belt for denials.
Great. Well, again, thank you so much for these real life helpful tips and advice. So I just want to say again, thank you, Sarah, for an engaging presentation, and thank you to our audience for participating today. The webinar and slides will be available on our website, which again is accc-iclio.org. And again, we hope to have that up by early next week. And then also, as a registrant, you will receive the email with the link to view the archived webinar. And please also, while you're on our website, register for our next webinar installment, which is going to be on November 23rd, so next week, with Dr. Stephen Powell, who was our first ICLIO Innovator Award winner. And he's going to present on expanding access to immunotherapy in the community setting. And also on December 1st, Dr. Michael DeLeo is going to present on the emerging role of the radiologist with IO. So again, please register and visit our webpage, accc-iclio.org, to register. So thank you so much, and enjoy your weekend.